This is a tutorial about a mode of ventilation that's been around for several decades for the management of patients with severe acute hypoxic respiratory failure, and that is airway pressure release ventilation. It's found a new lease of life over the last couple of decades since the introduction of bilevel modes of pressure control ventilation. Tutorial 29. This is part of the Advanced Modes of Mechanical Ventilation series, and this is Airway Pressure Release Ventilation, otherwise known as APRV. Previously, I introduced bilevel pressure control as a modern mode of ventilation, and I explained what makes this different from other modes, the presence of an active exhalation valve, and this is really relevant to this particular tutorial. The reason why this is important is because bilevel pressure control allows the patient to breathe spontaneously at both levels. That's a low pressure level, otherwise known as PEEP, and high pressure level that is analogous to the pressure limit. I explained the difference between pressure limitation and volume limitation, how to set up bilevel pressure control, and the strengths and limitations of bilevel. The major strength is you can use this mode of ventilation for pretty much any patient in the ICU at any time. This time I will discuss an advanced setting in bilevel known as airway pressure release ventilation, and I will point out that airway pressure release ventilation existed long before the active exhalation valve, but when the active exhalation valve became available in the late 1990s, this mode became quite prevalent for use in critical care in patients with ARDS. I'll explain how you set it up and a clinical strategy, and when not to use APRV. Let's start with a clinical scenario. You're in trauma ICU and you see Harry. And Harry is a motorcycle courier who was struck by a van, and he has extensive injuries and had a massive resuscitation that included a spinal injury. So he's being log rolled. 3 days after arriving in the ICU, that's 3 days after this big resuscitation, he starts to develop acute hypoxic respiratory failure. And at this point in time, his PF ratio is 90. That's the PaO2 divided by the FiO2. Remember, below 200 is not good. Below 100 is severe hypoxemia. And he's been on volume assist control ventilation, 400 mils with a PEEP of 15 and a rate of 30. And his gas exchange is not great. He has been given neuromuscular blockade, but that doesn't really change the PF ratio. Prone positioning is not an option for him. So what can we do for him on the ventilator? Well, to explain what we can do for him, which is airway pressure release ventilation, there are a few other things, and I'll mention them in a few minutes. We need to go back to lung volumes. The most important lung volume to understand is the functional residual capacity. And this is the resting lung volume. It's 30 mils per kilo, and this is where oxygenation occurs. It's the amount of gas that's held in the lung at end expiration. Above this, we have tidal ventilation, and that is 5 to 7 mils per kilo. The major purpose of tidal ventilation is to clear carbon dioxide. It does refresh oxygen to a certain extent, but it's mostly about clearing carbon dioxide. And that's our standard breathing apparatus, about 37 mils per kilo. But there is more space in the lungs to expand. Now, the lungs aren't half inflated. They inflate to where they inflate. They're elastic objects. So to inflate them further, you have to stretch them up. But you can stretch the lungs up another 40 or so mils, and that is known as the inspiratory reserve volume. And the inspiratory capacity then is everything that's above F4C, and that's about 50 mils per kilo, giving a total lung capacity of 80 mils per kilo. So that's what you have, 80 mils per kilo of total available lung tissue. Now I'm going to redraw this in a kind of a simpler way, and we're going to start with a big circle. So we have 80 mils per kilo of total lung capacity, and then we're going to add in F4C, and that's 30 mils per kilo, and on top of that we're going to build tidal volume of 7 mils per kilo, and our inspiratory capacity then is 50 per kilo. Virtually every disease that you will encounter in hospital medicine that impacts lung parenchyma, that's the lung tissue, causes lung volumes to fall, whether it's sticky lung, soggy lung, etc. So if a patient aspirates or has pneumonia or has pulmonary edema, their lung volumes fall. So in this situation, the total lung capacity has fallen by 10 mils per kilo, and this has a knock-on effect on the other lung volumes. The functional residual capacity falls, and this results in phasic atelectasis and right to left shunt. The body will attempt to generate normal tidal volumes, and it may well do so, but the work of breathing is significantly higher because the lungs are most compliant at FRC. When the lung volumes drop, it's much harder to reinflate them. So the pressure volume relationships are poor. So you can see here the tidal volume that is achieved for the airway pressure is much lower than you would expect. The conventional approach to dealing with this is to apply PEEP or CPAP. And what that does is by applying pressure at end expiration, particularly, it prevents end expiratory lung collapse and recruits some collapsed lung tissue. This purpose of this is to restore functional residual capacity and restore the surface area for gas exchange. And this is reflected by better pressure volume relationships. However, as lung disease progresses, more and more PEEP is required. There is an alternative strategy, and that is to increase inspiratory time. With really severe lung disease, PEEP may become completely ineffective at recruiting and restoring FRC. So what do you do? As long as there is some inspiratory capacity exemplified by the ability to deliver a tidal volume of some shape or form, and the airway pressures may be quite high here, one can actually flip the breathing cycle so that the oxygenation reservoir is inspiration, and the time that you spend in inspiration is a long time, and then you release to expiration. You inspire, hold it there for ages, and then expire. So the resting lung volume is inspiration, not expiration. So everything is upside down, and this is known as inverse ratio ventilation. It's like setting a really high level of CPAP and then just occasionally releasing a bit of gas in order to get rid of carbon dioxide. It's also the principle behind high frequency oscillation, but the way you get rid of CO2 is a little bit different. So high airway pressures, because you fill what's left of the lung with oxygen, using as much of that inspiratory capacity or inspiratory reserve volume as possible, whatever's left of it, because the FRC has been devastated by disease and fluid and pleural effusions, and that's where your oxygenation is occurring. Now, in terms of a flow chart for how to manage a patient with profound hypoxemia, this is the way I do it. If a patient has profound hypoxemia with a PF ratio of less than 100 acutely, I give neuromuscular blockade based on the evidence from the Acute trial. Once the patient is paralyzed, if the gas exchange doesn't improve spectacularly, there is one question to ask: is there any reason not to turn the patient prone based on the PROCEVA trial? If there is no reason, and there shouldn't be for the vast majority of patients, you turn the patient prone for 16 hours a day and keep doing so until the gas exchange improves. If you are not able to turn the patient prone, and that is the case with our patient here, because he has a spinal injury, you cannot be flipping him back and forth as you may paralyze him. In that case, we're into rescue therapy. There are some complex rescue therapies out there. The most extreme is extracorporeal membrane oxygenation. This takes place in specialist centers, and he will have to be transported to a specialist center to get that. You can also give inhaled nitric oxide, but this is a short-term remedy, and unless there is a very rapidly reversible process, it is not terribly effective. It works for a short term while you reverse them, but it's not going to fix this patient. Third alternative is high frequency oscillation. I will cover this later on in the course, but I will point out that there is really no evidence to support the use of this particular approach currently. The easy way to manage him is to use a mode of ventilation known as airway pressure release ventilation. Now, I will say one thing about Harry before you even start fiddling with the ventilator or thinking about anything else. He's 3 days after a major trauma. He's had a major resuscitation. You need to consider de-resuscitating this patient. A lot of these patients will actually respond very well to diuresis, and soggy lungs is a major problem after major resuscitation. At this stage, the stress response is likely burning itself out, so I would give him furosemide, 40 milligrams IV, and then an infusion of 10 milligrams per hour. This increases the unstressed blood volume, it improves renal blood flow, and promotes diuresis of crystalloid. If you want to know more about this, there's a whole course on fluids that I have up on my blog and on YouTube. But let's move on to airway pressure release ventilation as a rescue therapy. Airway pressure release ventilation is not a mode of ventilation per se. It is a ventilatory strategy, and it's often known by the abbreviation APRV. It is used exclusively in patients with severe hypoxemia where prone positioning is either not possible or it's ineffective. And what it is extreme inverse ratio ventilation, such that the baseline airway pressure is the P high, the high airway pressure in bilevel, for example, or the inspiratory pressure limit in pressure control. And then that high pressure intermittently releases, for example, for 0.6 of a second or less, down to usually atmospheric pressure. And the purpose of that release is to remove carbon dioxide, but at the same time maintaining mean airway pressure. So it's quite analogous to CPAP with intermittent releases. It works really well with modern ventilators because of the use of the flutter valve, allowing the patient to breathe spontaneously. The patient doesn't need to breathe spontaneously. Certainly this patient who has neuromuscular blockade will not be in a position to breathe spontaneously. So in his case, this is what his airway pressure waveform will look like. Note that the baseline airway pressure here is not PEEP, but the high pressure level. The pressure is released for a very short period of time, in this case 0.6 seconds. The purpose of the release is to ventilate the patient, that is to remove CO2, so the release ramp needs to be as steep as possible to remove CO2 while still retaining a high mean airway pressure. Here we have a release tidal volume of 450 mils, which is our target. In this situation, we've set the low pressure level to 0. To many intensivists, using 0 PEEP is an anathema, but usually the pressure doesn't really drop to atmospheric. Usually there is some level of controlled auto PEEP, and this in itself is a little bit controversial. It's been my experience that some patients actually get down to 0 and some don't, and honestly, I actually don't think it matters that much. Even if the airway pressure reaches 0, that does not mean that the lungs derecruit and rapidly reinflate. The diseased lung units have very, very long time constants, and the short release time barely clears out the dead space. And in this situation where the patient is not breathing, the minute volume is a respectable 4.5 litres. Unfortunately, given the lung disease necessary to require this mode, much of this ventilation will be wasted and hypercapnia is to be expected. And we call this permissive hypercapnia, and there's nothing much you can do about it, and frankly, it's not terribly harmful. Harry has been paralysed with neuromuscular blocking agents for 2 days, and we've diuresed off several litres of fluid, and now we need to allow his diaphragm work to prevent further diaphragmatic atrophy. To allow Harry to breathe spontaneously, you need to use the bilevel mode. APRV can be achieved with difficulty in volume control and fairly easily in pressure control, but spontaneous breathing really requires the active exhalation valve that I discussed in the tutorial on bilevel pressure control. I'm going to draw a pressure limit here of 30 centimeters of water. The reason for this, of course, is because decades of research have shown that lung stretch beyond 30 centimeters of water is associated with ventilator-induced lung injury. So let's see what happens. You can see that Harry is taking spontaneous breaths, while the ventilator is facilitating them while maintaining airway pressure. There's quite a lot of spontaneous breaths here, and this is something that causes a bit of distress sometimes to bedside practitioners who see a respiratory rate of 25, 30, 40, and they think the patient is in trouble, but in fact they're just panting away. And the value of this is that it dramatically increases the minute ventilation, and this will help clear carbon dioxide, and it has certain benefits beyond that point. And these are the proven advantages of airway pressure release ventilation with spontaneous breathing. The first thing is that oxygenation is unquestionably improved because of recruitment of the posterior dorsal segments of the lungs. Secondly, there is improved ventilation, and what I mean by that is carbon dioxide clearance is enhanced due to increased minute ventilation. There is also an increase in cardiac output due to an increase in venous return, increase pulmonary and in global blood flow. So these are all good things. But remember, this is a patient getting an extreme mode of ventilation. It's not for everybody. It's for patients with severe hypoxic respiratory failure and low lung compliance. And I will make the point that while spontaneous breathing is good, it is not essential, and gasping is bad. Patient selection is critical, in my view anyway. There should be diffuse, not localized lung disease. So lobar pneumonia, not a good candidate for APRV. Diffuse pneumonia that you see with bronchopneumonia or aspiration pneumonitis, generally pretty good candidates. I believe that the compliance should be less than 30 mils per centimeter of water, or actually lower. If the lung compliance is relatively normal, this mode of ventilation is a waste of time, and it'll cause trouble because the mean airway pressure is very high in this mode of ventilation, and if the lungs are relatively compliant, then that pressure will transmit to the heart and to the great vessels, and it will exceed the mean systemic pressure, reduce venous return, reduce cardiac output, and reduce blood pressure and tissue blood flow, and this is a disaster. So you don't want to get into that. If you put someone on APRV and their blood pressure tanks almost immediately, you need to take them off. Now, it can be used briefly as a recruitment tool for a couple of minutes. You put them on this and it's perfectly fine, but you need to remember to go back to conventional strategy. And frankly, nobody knows what the end inspiratory lung volumes are in airway pressure release ventilation. There are lots of people out there who will tell you, no, you should not exceed 6 mils per kilo of tidal volume in patients who have acute hypoxic respiratory failure. However, that is entirely possible in airway pressure release ventilation, because even though the release volumes may be fewer than 6 mils per kilo, with that little extra bump of the spontaneous breath, who knows? Also, really don't know what the transpulmonary pressure is either. In terms of the settings for starting a patient on airway pressure release ventilation, I can tell you that there is absolutely no consensus on this, and every intensivist that uses this mode has their own opinions, and these are my opinions, and you can take or leave them. I have a fair amount of experience using this mode, but again, there's other people who use it a lot more often than I do these days. So what I will tell you, there is no consensus. And generally, if you have a patient who has diffuse lung disease with poor compliance and they have a very low PF ratio, I think you got to start high. And I would put the patient on a P high of 28 centimeters of water and then work my way down. And then I set the P low at 0. Now, the reason for setting the P high at 28 and not 30, of course, is the issue of the spontaneous breath. That little extra bit of positive pressure on expiration will abut the 30 centimeters of water pressure limit. The P low of 0 really is all about controlled auto-PEEP. Sometimes they get there, sometimes they don't. And if your tidal volumes are a litre, you have to wonder if this patient should be on this mode of ventilation at all with that very short release time. That is the big issue here, of course, the expiratory time and how little time you use. And it's my view that you should take a simple approach to this, and I think 0.6 seconds is a pretty good default. Now, there is a scientific way of doing this using 25% of peak expiratory flow, but most people don't do it, and I wouldn't expect our bedside practitioners to be fiddling and sciencing it out. It's a nice thing to do if you've somebody established an APRV, trying to get that right, but initially you want to have something that you can just lock the patient on, and I think this is a good way of doing it, and set a goal release volume of less than 6 mils per kilo. So if your patient is a regular size male. That will be about 420 mils. For an average size female, you're looking at 350, 370 mils. If the tidal volume is too big, then you can either reduce the expiratory time, but be careful, because remember, you need some alveolar ventilation, or else add PEEP. If it's too low, you can increase the expiratory time up to 0.8 seconds. Now let's look at setting the rate and the inspiratory time, because that can be a little bit tricky. How do you decide on this? I want to point out that what I'm going to show you here is back of the envelope calculations that I did. This is not published anywhere. And in this diagram, I have placed the airway pressure in centimeters of water on the y-axis and the I to E ratios on the x-axis. That's on the bottom. I've set the high pressure at 28 centimeters of water and the low pressure at 0. The expiratory time is locked in here at 0.6 seconds and not varied. As we are doing extreme inverse ratio ventilation, I'm starting off with a ratio of 3.3 to 1, corresponding to 23 breaths per minute, and then reducing the rate progressively until we arrive at 6 breaths per minute, or a ratio of 15 to 1. You can see here the respiratory rates are on the top. What we want to do is maintain a mean airway pressure of 25 centimeters of water or more without spontaneous breathing, while giving as many breaths as possible to remove carbon dioxide. So let's see what happens. The red line corresponds with the high pressure and the green line is the mean airway pressure. You can see that the inspiratory times become longer and the rate fewer, and the lines come very close together, but the difference reduces progressively. And that is quantified by these negative numbers that you see here, the difference between the high pressure and the mean airway pressure. And it would appear to me, if you look at these numbers, for example, at 23 breaths, the difference between the dialed up high pressure and the mean airway pressure is minus 6.5. That's a lot. At 6 breaths, it's minus 1.75. That's very, very little. But we have very few breaths. And it seems to me that the optimal respiratory rate here that gets you pretty tight between the mean airway pressure and the pressure high is somewhere between 8 and 10 breaths per minute, and that corresponds to an I to E ratio of 12 to 1 to 8 to 1. So you're in that kind of range. Of course, you could give 12 breaths per minute if you wanted to, but that's what we're looking at, a 0.6 second expiratory time and probably 8 to 10 breaths per minute. Fewer breaths than that really make very little sense, because you can see here the difference between 9 breaths and 8 breaths is marginal. 9 breaths to 7 breaths really only about 0.5 of a centimeter of water of an increase in the mean airway pressure. What about the settings on the ventilator? So let's have a look at the different settings on the ventilator to put a patient on airway pressure release ventilation. First of all, we use bilevel. Now you can use pressure control if your patient is paralyzed, but it's so much easier to use the mode of ventilation for which this has been used for many years now. The spontaneous breath you can set at either tube compensation or pressure support. Normally this will only be on the low pressure level, and you're using airway pressure release ventilation. To me, it makes no sense to have any pressure support at any stage. So my inclination here would be normally to turn this off or just put the patient on tube compensation. And then of course we need our flow trigger and our V-sense. So that's so the patient can breathe away. And that's our conventional flow by trigger between 2 or 3 liters per minute above the base flow. The pressure high is set here at 28 centimeters of water, as I previously mentioned, and the pressure low set at 0 centimeters of water. Because it's pressure control ventilation, you also have to put in a rise time or slope, and it's set on the Puritan Bennett ventilator at 70%. And I've set the pressure support at 0, but I could have set tube compensation. If you're putting a patient obviously on pressure support, you usually have an expiratory sensitivity. And even on this particular ventilator, pressure support of 0 really corresponds to 1.5 centimeters of water of pressure support. So just be aware of that. And that's another reason for keeping that P high lower than 30. So imagine that I've instructed you to put this patient on airway pressure release ventilation. I go off and I come back, and the first thing I say is, you have made a mess of this. Pause the video now and see what's wrong with this picture. Okay, so you're back. This is obviously airway pressure release ventilation using the bi-level pressure control mode. And here we have clearly evidence of the patient breathing spontaneously, and this is how airway pressure release ventilation works at its best. So this is good. However, the big mistake here is that the low pressure was set at 6 centimeters of water. Now this is translated to an inadequate tidal volume of 193 mils. Now it may not always be that low, but that is just too low. And the reason why is that the release is just insufficient. There isn't enough gas escaping in the time window to give the patient a proper tidal volume. So I would come, for example, and change the settings. And you can see here I put the P low at 0 and the tidal volume is a nice generous 436 mils, in and around what we want. The reason why the waveforms look a bit different here, by the way, is that I just changed the scale so that you can actually see what's going on. And this is quite an extreme I to E ratio, but it is a gorgeous picture. If you just fix this in your mind, you can observe all three waveforms: pressure, flow, and volume. 1, 2, 3 on the screen. If you go to the pressure waveform, you can see a spontaneous breath here, slight negative deflection on inspiration, slight positive deflection on expiration. This translates to some positive flow on the flow waveform, and subsequently a tiny little tidal volume at the top of the volume curve. So the patient has volume in the lungs, then a little bit of extra volume. And that's why I point out that we're not really sure what the end inspiratory lung volumes are. There is an estimate of it there on the screen, but who really knows? On the Draeger Evita Infinity ventilator, APRV is a standalone mode of ventilation. Now, there is nothing different about APRV versus bi-level. And you would think, well, why not just configure APRV from bi-level? But you have to understand the manufacturers. Draeger wants you to use bi-level as your standard default mode of ventilation in the ICU. And so when you turn on the ventilator and hit bi-level, a certain set of standardized settings may come up. For example, a 1 second inspiratory time, a high pressure of maybe 15 centimeters of water, a PEEP of 5 centimeters of water, etc. And if you want to put the patient onto APRV, when there's a lot of fiddling goes on, and the risk of somebody doing something stupid is quite high. So it makes an awful lot of sense to have bi-level pre-configured for a standard patient and then have APRV configured as a standalone mode, even though it is for all intents and purposes bi-level. And so when the operator just goes to APRV, a standardized set of settings just appear. In this situation, you can see the settings here. The patient is on pressure control, high PEEP at 28, low of 0, high inspiratory time of 4 seconds, a low expiratory time of 0.6 seconds. And I think this is a really good way of doing this. And I think it's much better than all the fiddling that you have to do, for example, on the Puritan Bennett ventilator, which is very frustrating because you have to lock this, unlock that, etc., etc. It just does what it says and gives the patient APRV. And I think this is the way that ventilators need to be operating this mode going forward. Now, I want to say a couple of things about what happens once you've put the patient onto this mode of ventilation. And this is a really key point to make. Hypercarbia may be a sign of excessive lung stretch. Hypercarbia in airway pressure release ventilation is multifactorial. It is caused by a combination of hypoventilation overall and increased alveolar dead space secondary to hyperinflation of poorly perfused lung units. I don't want to be overly prescriptive. The major purpose of APRV is to keep the patient alive by keeping the PaO2 at more than 60 millimeters of mercury or 8 kilopascals. Now, if someone has long-term hypoxic respiratory failure, they might tolerate something a little bit lower than that, but you're really into a danger zone. On the other hand, if by putting the patient on APRV, the PaO2 goes up to 80 millimeters of mercury or 10.5 kilopascals, and the PaCO2 is more than 60 millimeters of mercury or 8 kilopascals, well, now you have a little bit of wiggle room. It's my belief that many intensivists disregard hypercarbia as if it's not important, Yes, CO2 is fairly well tolerated by the patient, but other things need to be considered. And the possibility here is that CO2 is high because the lungs are being overstretched. Because again, we're never sure how high the P high should be. And if they're being overstretched, they're being damaged. And damaged, overstretched lungs amplify the inflammatory response. So what do? If the minute ventilation is relatively low at 50 to 70 mils per kilogram, then the alveolar ventilation needs to increase and you can increase the respiratory rate. If the tidal volumes are lower than 6 mils per kilo, then you can increase the release time. Alternatively, if the PaO2 is acceptable and the CO2 is high despite a minute ventilation of 10 mils per kilo with a normal range blood pressure, then the P high should be reduced gradually. There comes a point where a patient like Harry will start to recover his lung function, the lung injury starts to reverse and he's getting better, and it's time to start weaning the patient from airway pressure release ventilation. This is a bit of an art form. There's lots of ways of doing it. This is just one suggestion, but you can do it any which way you want. I would suggest, though, if the FiO2 is less than 50%, or the PF ratio, that's the PaO2 divided by the FiO2 in millimeters of mercury, is greater than 150, then it's time to really go back to a conventional mode of ventilation. As they're likely already on the bi-level mode, you can just adjust the settings so the patient goes to a conventional version of bi-level. But of course, you could put them on pressure assist control or indeed volume control, although that doesn't make an awful lot of sense because you're already on pressure control ventilation. At this point, I would add a low PEEP of 10 centimeters of water. Now, this might seem to be quite low for someone who's had severe hypoxic respiratory failure, but as I pointed out in the tutorial on pressure control, because you're using long inspiratory times, you really need to lower the PEEP level, again for the same reason as you use airway pressure release. You need that big ramp from the high pressure to the low pressure to get carbon dioxide out, and then you progressively reduce the I/E ratio from 3:1 to 2:1 to 1:1, and then you start to reduce the high pressure, the pressure limit, and convert the patient to a regular 1:2 I/E ratio. And then if they're breathing up very well, of course, it's time to put them onto pressure support. If you're going to go with pressure support, you might need to turn up the PEEP a little bit. What about the limitations of using airway pressure release ventilation? In my view, this is a mode of ventilation exclusively for patients with hypoxemia and very low lung compliance. The mean airway pressure is very, very high. With low compliance, airway pressures are not transmitted to the heart and great vessels, but a combination of hypoxia and normal compliance and airway pressure release ventilation equals hypotension. And hypotension is not great because as soon as the patient becomes hypotensive, someone either floods them with fluid or puts them on vasopressors. The vasopressors will increase pulmonary arterial resistance. That makes the right heart pump harder and pump uphill. The inflow of blood into the right heart is inadequate, and that just gets into a vicious cycle. So if you put someone on APRV and their pressure drops very soon afterwards, you need to let the pressure off and see what happens. So let's review this tutorial. This was a discussion about airway pressure release ventilation, otherwise known as APRV, and it's a mode that's used for treating patients with severe hypoxic respiratory failure. I started by explaining why extreme inspiratory times may be necessary due to complete loss of functional residual capacity, and what you're essentially doing is using tidal ventilation as the baseline airway pressure and releasing down towards what would have been F4C. I explained how to set up APRV. This is usually done in the bi-level pressure control mode, but it can be done in pressure assist control. But in that situation, you cannot let the patient breathe spontaneously. Ideally, the patient should breathe spontaneously, but it's not essential, and particularly in the acute phase of ARDS, it may be better if the patient is paralyzed and not gasping and causing stretch-induced lung injury. I discussed the clinical strategy for using APRV, when to use it and when not to use it, why it's good, and the complications of when you use it in the wrong patient in the wrong way. Thanks for reviewing this tutorial, and I'll see you next time. So that was airway pressure release ventilation. I hope you found it useful. If you're enjoying these tutorials, don't forget to follow me at ccmtutorials.org and subscribe to my channel on YouTube at CCM Tutorials.